Good morning. Welcome to our critical appraisal session. So as a continuation of our critical appraisal of observational studies, we have recently had cohort case control. So as a continuation, we'll be having a session on critical appraisal of a cross-sectional study using the CASP questionnaire. And I'm happy to welcome Dr. Vineeth to do the critical appraisal, and he'll be appraising an article which was published in JAMA Network. I'll hand over to Dr. Vineeth for the session. And any questions from the online participants, please feel free to put it up in the chat box, or at the end of the session, please feel free to unmute yourself and ask your questions as well. We welcome as many questions as possible from the audience. Once again, thank you for joining. I'll hand over to Dr. Vineeth.
Good morning, everyone. Today we'll be using the CASP checklist for the appraisal of this article, Adolescent Treatment Landscape of Depression, Suicidality and Substance Use Disorder in the US. It was published in JAMA on August 29, 2025. So, coming to our case, Mrs. S brings a 17-year-old son who has recently got admission in an engineering college in another state for a health checkup prior to joining college. After he's done, she wishes to ask you some questions in private. She is concerned about her son as he has a history of substance abuse in the past. She has heard that it leads to increased risk of mental health issues and wants to know if he'll seek help. What advice would you give her? So, So, did the study address a clearly focused issue? So, what is the treatment landscape for adolescents and young adults aged 12 to 20 years with depression and suicidality, related mental health and substance use disorders from 2021 to 2022? So, the thing is, it's a very broad topic. And so, if we see the PICO statement, actually, the population is adolescents aged 12 to 20 years. The variables of interest pertinent to our question are mental health disorder in persons with substance use. The comparator is mental health disorder in persons without substance use, and the time period is 1 year that they followed. But the overall study that they did was a very broad study that looked at multiple things. So, did they use an appropriate method to answer the question? So, the question was point prevalence, and cross-sectional study is a good study to evaluate for point prevalence. Further, the only other thing is they could have used a cohort, but in view of the sensitive nature of the issues involved, it may not be the most pragmatic of study designs in the current situation. So, cross-section study is a fair study to estimate the point prevalence of what we're looking for. So, were the subjects recruited in an acceptable way? So, they actually based their study on something called the National Survey on Drug Use and Health. It's a household survey of non-institutionalized civilians in the US. So, the problem is that it excludes all unhoused or unstably housed or incarcerated or institutionalized adolescents who are receiving inpatient or residential treatment. So, the problem is from the US, this is how this study is done actually, the NSDUH. They actually go home to home and they contact adults and adolescents within the home. They are randomly selected and then they are actually studied to get the. So, that is how we usually get the response. So, if you actually see, it's conducted in 50 states in the US. An adult resident of the household will answer general questions. After that, 1 or 2 members of the household may be chosen to be part of the interview. And so this is how it was done. The problem is because of this, there's recall bias, and it's not directly being asked to the people who are involved. It may be asked to the other members of the family, and then they may not be aware of the actual situation that's happening. So further, this is also data from the US. This reports that most homeless people have mental health disorders or substance use disorders in the US. Actually, across all categories, they have alcohol, substance use, all that. But this study only looked at people who are staying at home. They excluded all non-house people, all institutionalized people. So it may not have been a very representative sample of the whole population. So coming to were the measures accurately measured to reduce bias? So these are the 4 main variables they looked at. They looked at mental health diagnosis, substance use, receipt of any mental health treatment, and any substance use disorder treatment. So they actually see this was how they looked at each of the variables. So mental health and substance use, they use the DSM-5 criteria, which is a validated score and it is objective. So they can use it to evaluate these patients. But for mental health treatment and substance use treatments, they had a variety of things which were, for example, in mental health treatment, they talked with parents of the children. And that was considered, if the parents knew that the child was receiving help for mental health, that was considered enough for that. And also, for example, in mental health treatments, is alternative help. That is, if they visited any faith healer or anything like that, that was also considered valid for mental health treatment. So there is no proper documentation or any this thing. So 2 of the 4 variables that they looked at, many of those criteria that they looked at were not objective and were not clearly defined as to what constituted treatment for that. However, the mental health and substance use was with validated DSM-5 criteria. So, were the data collected in a way that addressed the research issue? So, the problem with the data collected was from NSDUH, and we already saw multiple problems with that study. They completed the interview online or in person. So, with regard to the sub questions, the setting for the data collection may not have been ideal because the primary population we're trying to catch may have all been not at home. They may have been institutionalized or homeless. They may have found a significant amount of drug users, substance users. And they have clearly defined how the data was collected. It was by an interview or questionnaire. And they have not really justified the methods, although this was the way that they used. They used the data from the study. And so that is why we labeled it as no. We thought the setting was not appropriate for the data collection. Did they have enough participants to minimize the play of chance? So they had a very large sample size, 32,598 adolescents, who are a weighted population of the total adolescent population of the US from estimates. So they've clearly, the sample size is large, but again, the problem is whether it's an actual representative of the population is the problem. So that's why we said no to that. So summary of the internal validity. Did the study address a clearly focused research issue? No. Did the authors use an appropriate method? Yes, the cross-section study was probably the appropriate method. Were the subjects recruited in an acceptable way? No. Were the measures accurately measured? Again, some variables were not objectively measured. Was the data collected in a way that addressed the research issue? The setting may not have been the best for collection. And did the data have enough participants to minimize the play of chance? Again, it's difficult to tell because the data was indirect from the adults in the population.
So first question is study address the clearly focused issue. Maybe the issue is the problem with the way the study was conducted or the question on research question.
So the research question was very, very broad. They looked at mental health issues, they looked at substance use issues, they looked at mental health treatment and substance use treatment. Okay. So because of the broadness is why it wasn't very specific to sort.
They are taking from their population side. Is that a valid question for them? Or is that a focused enough question for them? Yes, it will not be scientifically exceptionally accurate or well conducted. But in the context of their population, is that a valid or acceptable use? Because finding these patients and getting data from them is another even big task. You won't even know when they have to be one or they are actually willing to open up an answer. So, I mean, from my perspective or from the population perspective, I feel that it may be okay for them to do such a study because that's a, let's put it to the most practical way of doing it.
Right.
If suppose somebody comes to my house and says, okay, we have a relationship to me, have family, my wife or my father, I know. Probably for them, that is the practical way of doing it. But scientific may not be. And that's why they are coming up with even pragmatic clinical trials, not just okay, 100% we are going for a college because the real world is much different from what is I will flat out say no to the first question. I would say okay, no from a scientific perspective, but from a population or from collect this data or suppose this is the valid data, I would say it's a very valid and important. That's why those are.
One of the other ways, say, suppose I had to do what would I do? How could I make it better? Here they try to correlate depression with substance use at one point. You have to measure 2 things. There's no, even though you say that it's not focused on one measure, they are trying to look at 2 measures simultaneously in a cross-section. So you have to measure those 2. You are saying the subjects were not recruited acceptable because our idea is that more of the homeless people are likely to have drug abuse and mental health disorders. That may be a limitation, but that can't be the limitation for all the answers. So for the focus question, I think is yes and no. Yes, because they were looking at trying to correlate 2-3 things. So they had to ask a little broader. Recruitment, that probably is no. The measures, are there any more accurate measures?
So,
Suppose we have to do a better study. Suppose we do it Vellore. Because you may have a better score of depression. But then remember, you have to do 38,000 people. If you have one-page question on depression itself, nobody will fill up the question. I'm just saying.
yes.
So you see that, okay, this is a fantastic score, but it's not practical for a large community-wide survey. So I'm saying, yeah, just the measurement would be better, but I don't know whether like it's practical to do 38,000 people with a big question. Data collection is one-on-one interview. So it's just that it has some bias, that's there. Participants, enough participants, that is based on the sample size estimate. So suppose you say, I think depression in 12 to 20 is 20%. Then you calculate the sample size for that. And you say how accurately you want to estimate that. If they were looking at correlation between depression and substance use, you specify the correlation coefficient and you calculate sample size. Did they give a more detailed explanation of sample size?
No.
So that's okay. But if you just generally look at it,
don't say anything about have the reply, even 60,000 patients, any study would be have value.
No,
Statistics are not.
they had 50 states.
Yes.
How did they select participants in 50 states? Was it a random?
They have said they use scientific methods in the NSQDH. Actually, this
Ah,
study is
the
expected.
government. It's like India does annual family health survey,
Yes.
and then it's just national family health survey. That is done in some particular
Yes.
method. So we'll have to go and look at that NSGS methodology. So suppose we are doing a large cross-sectional study, we should get all the population, randomly choose, let us say Tamil Nadu. In Tamil Nadu, we choose randomly 5 districts. In the 5 districts, we choose 5 random 10 taluks. In each taluk, we choose 100, 100, 100. So it comes up with a number. So they would have had some methodology, but we shouldn't say the methodology is not good, but they would have had a scientific methodology show that the main thing is randomly the subselect represents the whole population. Okay.
So, what are the results? So, how are the results presented? What is the main result? So, the total population was 32,598 adolescents. And here they said 13% had substance use and 24% had a mental health diagnosis. And only 10% of participants with substance use and 51% with mental health received treatment. So, in terms of the sub questions, the results are presented as a proportion in terms of percentages. And how large and how meaningful it is, we'll see in the subsequent slides. How would you sum up the bottom line? That is the summary. So 13% and 24%.
Have you given the confidence intervals for those?
No, sir.
There's no table of results.
It's only the percentages. In fact, the absolute numbers also they are not mentioned there. Even the supplement is the percentage. Yeah.
But they have given the absolute percentage. So they could have
Yes.
given the confidence interval for that. So
Yeah. Yeah, with that CA calculator.
So this is, so the main result is there's a difference in substance use disorder between men and women.
There was a mild difference of 53-46 between men and in fact women were more than men in substance use disorder. Then the other thing I wanted to highlight is as the age group went up, actually the substance use disorders kept going up. So from 12 to 13, 14 to 15, 16, 17 and 18 to 20 kept increasing. Over
There itself you can see the effect of a sample size. 50 and 40 is 50 plus or minus 3. Even that is coming in
significant because it's so that's why we put it as content because the sample will justify anything, but we don't know if it was a.
Suppose it is 30,000 people, 38,000. Assuming that the equal number in each group, 1, 2, 3, 4, 5. So 40,000 divided by 5, maybe 8,000 in each group. So you can there will be reasonable numbers. So is it a general assumption that as we grow older, substance use goes up?
So there were a lot of variables which I didn't come in on. One is reporting itself.
No. Is this something which fits into our existing knowledge that as we grow older, substance use goes up?
So in adolescents, I did find a couple of studies which show they say access improves as you grow older. 12-year-olds are less likely to access than 16. But these are all like small.
Another thing that they're showing difference is race and ethnicity is different. Which are the highest substance use?
Actually, the is whites and then the yes.
I don't know that maybe I'm wrong. I was thinking that black and Hispanic will have higher substance use than white population. That's my general understanding of US. I may be wrong.
I thought for trade, but they found out that.
So the only thing then we must go and see, suppose you go to households, maybe the white households gave permission to have the interview much more than black or Hispanic households. So you are getting more of that may be, so we need to find that subdivision. Okay.
Then some of the other important things is that you've been arrested prior to this, then your likelihood of substance use is much higher. And mental health diagnosis again was found to be significant, any diagnosis and with role impairment. So there's a major depressive episode, MDE, which is DSM-5. With role impairment is also that. Any diagnosis when they being any of multiple of those. So suicidal ideation, MDE or MDA role impairment. And opioid use also that was associated with. So even if they had any opioid use or opioid misuse, both are associated with increased risk of substance use.
But opioid is a substance use. So in the sense of
Like in the
amongst
sense,
the substance
use-
opioid is also. So the other 12% are non-opioid use.
yes, sir, they
Everybody has
substance
substance
use.
Or the non-substance.
This is substance use disorders. So they have used opioid, but they've not gone into substance use disorder.
So the main worry we had was mental health associated with.
Was substance use associated with
Either way. So there is an
There is
association.
an association.
Okay.
And this is some of their other tables which are not relevant to our point of interest, but any mental health treatment is again increased substance use is there for them. And this was some of the other things, socioeconomic status also. The Medicaid was found to be quite significantly, the fact that they had government insurance versus private insurance was also significant here. So overall, that was the main finding.
So what are the two, this is two age groups or substance?
This is age groups, sir.
Oh, it's not substance use.
It's not, no, so this is age group. This table is difference received by age sir, for treatment for substance use also. So was the analysis sufficiently rigorous? Again, they didn't give any odds ratios, they didn't give any absolute differences. It was only percentages that they said throughout the study. So.
They have said they use Poisson regression. No?
Yes, sir.
So have they reported the regression coefficient or the
They-
odds ratio relative race?
They've done they've not reported any odds ratios or risks. Sir. They've just said they've done the regression and they're multivariate correlated with the bivariate analysis. That's the only thing they've said. Even in the supplementary, they've not reported any odds ratios. That's the thing.
That's weird because we're trying to look at the association between substance use and depression. At least they will have an odds ratio. But I don't know whether they have some other publication because they said I've done Poisson regression. Maybe they published it somewhere else. Okay.
That would be look like a case control or whereas here
Even in a cross-sectional study, you can look at the association between two things. You can't make the conclusion of from association to causation is very difficult in cross-sectional. But at least you can say there's some association. So they have produced some p values. But they do need, and they said they have done Poisson regression and all.
That's then the study methodology becomes wrong. If you're taking those with substance use, those without substance use, those who have if that is the question, then
Even in a cross-sectional study, one can produce odds ratios. Since the title was, is there an association between?
no, the title is the landscape
Shape of this thing. They were just looking for point prevalence and everything.
But they have mentioned that they have done Poisson regression and all. But the results of Poisson regression have not been shown. Okay.
So is there a clear statement of findings? The findings, so the problems, the findings are reported as percentages. There's very minimal discussion of evidence against the researchers' arguments because they just haven't heard this thing. They have provided justification for their conclusions. One of the things that they said was access to drugs and all this more. And the findings are discussed in relation to the original question. Actually, they've reported everything as per their 4 original variables. That's how they've reported it. So can the results be applied to the local population? So actually we see that the Asian population in that study was very less. And in that the Indian population would have been even lesser. So about extrapolating it to this. And
it's not just about your Asian heritage, right? But like you can't just say ethnicity because clearly like drug availability, those are the primary factors in this question. So in this particular question, regardless of your race, I think you cannot apply to the local because everything
yes.
is entirely.
So that also I've written access to this thing will vary significantly with us. But in addition, the race also varies significantly. In the sense, the reason I put this is because even in their own conclusions, the race matter to drug use.
No, but there, when they say race, there, it affects their socio-economic factors. So like India would be your, like your, I guess, like class or that would be.
But they have reported that also as an independent thing. So socio-economically is independently associated with this, race is independently associated. So, yeah.
Question or anything.
Anything so.
This makes me worry. They have said we have done regression analysis, and we can adjust for the effect of A, B, and C, but they have not shown the results. That's a bit weird. No, but the question here is, they are done the study in US. We can't blame them for doing that. But do you think there will be any differences between what they got and what we will get if we did it here?
Yes, sir. Even in terms of reporting.
And that's the question. Is a local setting
Like
not reporting? Suppose we went to a household, not to the street side people and the homeless people. Suppose we did a household survey in India, would we get similar results?
Sir, yes, sir, because I mean, in the sense, we would not get similar results because the cultural factors are different here. There are a lot of other factors which drug availability, access to drugs, access to.
So their main result is 12% had substance use.
Yes, sir, 12% had.
Maybe 1%, but we will get.
No, so your main top line result is that 10%. Do you think that in India 10% of adolescents will be having substance use?
It depends on where you're doing it.
No, this is cross US now.
Like,
I'm saying this is cross US, they've done it across. I think it won't be wrong. I think we are underestimating substance use.
what
in India.
is substance
Any
use?
substance,
They-
opioid.
opioid is separate.
Opioid, what is that? What are opioid is that? So I'm thinking that, and 50% of adolescents have mental health issues. Nobody asked them. I'm just assuming that it may be 50%. So this is the question, whether this 10% is totally irrelevant to us, or is it eye opener? Hey, we also probably have substance use and mental health. Because we are culturally, racially different. But substance use is some substance. Ganja is available here freely. It's hardly costly. I'm saying that it's the same substance may not be there. But substance use, they may have more expensive substances to use, but our cheaper substances are available. Mental health, I'm sure, maybe more than 50% also. If you ask back to the question.
So, yes, sir. Can they be applied to cultural factors? Access to drugs and treatment may be different, and race is also some different factors. So, how valuable is the research? So, the thing is, although substance use disorder is a relevant and emerging issue in our practice, if you actually look at it, paucity of data in our population is a big problem. There are significant cultural and logistic differences in terms of access. So, they have documentation of every psychiatric consultation that has been done for their patients. In India, the documentation is not so easy. Resource availability to treat, and significantly more stigma associated with mental health in India. So because of that, this particular research to our question to answer this lady may not be so valuable to us.
No, they are asking the question.
Yes.
Have they compared with previous US studies?
They have not actually compared
In the discussion section, they should have said that 10% is less than previous studies or more than previous studies. So, I don't know, is there any Indian data on substance use in adolescents? Not made, not.
Yeah. Gone, just that would have made it like because even the.
or psychiatric clinics because
Psychiatric clinics might be a privacy.
No, this is not a separate study. They've taken data from an annual survey which goes on and presenting those results. So the National Family Health Survey in India, they have a fixed methodology so that if you change the methodology, then the results also will change. No? If you have a fixed methodology, every year the results you can compare the previous years. So they have done the same thing. I don't know if this is the first year they're doing the survey or this survey was done 5 years ago.
survey is done annually.
So then they could compare the results of the previous years and showed that hey, it's going up or coming down.
Survey is done annually. So the biggest limitation is actually using the survey data because
No, if they had discussed the contribution to the existing knowledge. So like I said, compared to last year's survey, it's going up. If it's going up in households, it's surely be going up also in the homeless people. Some statement they could use. Okay.
And they've not discussed anything about it can be transferred to other populations also. So overall with this. So coming back to our case, actually. So for this lady, we can say that with this study, there is an association But how much it is in our population and how likely, it's very difficult to say based on the studies. And that we will have to come to further.
Just go back to the results. Substance use disorder and depression.
The tables, right?
One table has substance use disorder and depression.
Yes. So this is substance use without substance use.
That is percentage, sir.
In percentages.
Actually, what we can do, we can put this as a 2 by 2 table. If you have the total, now keep that.
A total number is there.
So that you have to keep that, go to the next table. So you can make this as what, convert this 46 2 point into numbers. This 21.21 as numbers, and everybody else has no diagnosis. If 46% have, that means 54 don't have. And here the number will be 78 don't have. So we just make it into a 2 by 2 table using those numbers. We could have created an odds ratio for ourselves and say that these are the odds of substance use people having depression.
So that's the final conclusion, sir, for our, that this study may not really help us to answer that question. However, there is an association between substance use and mental health. So if he has prior, he's likely to have mental health issues.